Hello and good evening, everyone. Welcome to our 30-second Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Health Ethiopia, and it's a pleasure to have Dr. Alpha Seifu here with us to give us a presentation on the pediatric traumatic injury to the musculoskeletal system. To give you a background on Dr. Alpha is an assistant professor of orthopedic and trauma surgery and also a surgical care equity advocate. And on top of that, she's also a researcher and pretty active on her LinkedIn profile also.
So good evening, everyone. Thank you for the generous introduction, Adam. So today's topic of discussion for us will be pediatric traumatic injury to the musculoskeletal system. So this will be the outline of my presentation. I'll lay out some objectives for us for this session, and we'll review some basic sciences with regards to pediatric bone structure, and then we'll see the epidemiology of pediatric trauma, and we'll go through how to clinically approach these patients, and then we'll see injury types that are unique to the pediatrics population, and we'll also extensively discuss child abuse because it's on the rise, and the musculoskeletal trauma that's inflicted is a very common presentation for these groups of victims. And then after that, we'll see some general management options, even though specific management interventions are left to the specialist, but we'll see the general ways of approaching these patients. And then we'll see some common complications and then summarize. So our objectives are to understand the physiologic differences between adult and pediatric musculoskeletal system, to comprehend unique features of pediatric injuries, and to have a keen eye for fracture types that are unique to child abuse, and to also manage common pediatric fractures and understand when to refer to specialists. And finally, to know how to diagnose and prevent complications. So I'll go on. So just to recap basic sciences. So we generally classify bone into two, laminar bone and woven bone. Laminar bone is mature bone. It's the bone we find in adults. It's the bone we find in healthy individuals. So it's both the cancellous and cortical bone. That's the laminal bone. It's a well-structured, patterned kind of bone. So this is a microscopic classification. We don't generally use it in our clinical practice, but it's good to note that woven bone is not normal bone. So we find woven bone in either developing bone, like in children, and in fracture sites, and also at pathologic states, either in hyperparathyroidism or Paget's disease. So woven bone, although it's not found in adults, it's actually ubiquitous in the pediatric population. That's why the fracture patterns and the fracture, the nature of the fracture in children is very unique. So in terms of composition, the bone has both organic and inorganic components, and it also has living cells. So the living cells are generally classified as the stem cells or the osteoprogenitor cells, the osteoblasts, osteocytes, and osteoclasts. So out of these, osteoblasts are responsible for producing new bone, and osteoclasts are responsible for the remodeling. So what's peculiar about children is that they have hyperactive osteoblast and osteoclast activity. Since they're in the process of growing, you can imagine it as a fracture that's in the process of healing. So they have a metabolically hyperactive bone that's quite alive. So the nature of their injuries and also the pattern of healing is different in children. So children are not little adults. In addition to that, the composition of organic and inorganic matrix in children is different. So they have less inorganic component and more organic component. They have more collagen and they have also more other organic components. So it's important to note this. So generally, fracture heals in 3 stages, broadly classified: the inflammatory stage, the repair stage, and the remodeling stage. These stages are not, they are actually overlapping, and they differ from person to person, how long they last. So in children though, however, all of these phases are shortened. Universally, all of them are shortened. This is because they have higher healing potential. Children in general heal faster. In addition to that, children have something adults don't. They have a growth plate, which is responsible for a longitudinal growth or increase in length of bone. So here you can see the direction of growth is towards the metaphysis. So the growth plates, when we look at it microscopically, has 3 major zones. It has the reserve zone or germinal zone. It has the proliferative zone and the hypertrophic zone. So when children sustain trauma, they usually get injured through the hypertrophic zone. So having said that about our basic science knowledge, we'll go on to broadly classify fractures. So fractures can be classified using multiple methods. So I'll just use one, which is the etiological method. So through this method, it can be classified as traumatic, pathologic, and stress fractures. So traumatic fractures are a product of excessive force applied to a healthy bone. It can be direct trauma or indirect trauma. And pathologic fractures are a result of weakening of the bone. So the force is not strong enough, but the bone is too weak to handle it. And those fractures are a result of trivial trauma. And stress fractures are a product of repetitive microtrauma to certain parts of the musculoskeletal system. So there are common sites where stress fractures occur. So our interest today is traumatic kinds of fractures, but we will touch up on pathologic fractures because we need to learn to know how to differentiate these two, because children in general don't require excessive force to fracture even their healthy bones. So it might be easy to miss an underlying pathology or a pathologic lesion unless we look very closely. So here are some images just to put into your head what a pathologic fracture would look like. Here you can see the fracture itself, but if you look closely, you can see that the bone itself is not healthy. There's an already underlying lesion, which is not a product of the trauma. So it's important to have a keen eye and identify pathologic fractures as early as possible. So having said that, now let's move on to epidemiology of pediatric trauma. So injuries are the most common reason for a pediatric visit to the emergency room, and most of the mechanism of injury in children, unlike adults, is actually fall. So 70% are related to falls, whereas in adults, it's road traffic accidents is becoming the primary reason. So like I said, this represents 10 to 15% of ED visits, and in polytrauma patients, at least in 50% of them, we find some kind of musculoskeletal injury. So yeah, more of the same. So we know that trauma is more common in boys than girls, and the rate increases with age, but physial injuries, like they increase with age as well. So how do we approach a patient with trauma? Just like any trauma patients, pediatric patients should go through the ATLS protocol. So we have to follow the ATLS protocol and not treat the fracture, but treat the patient. So I think most people are familiar with the ATLS protocol, so I will not go into that. I'll go directly into how we approach the fracture now. So in our history, unlike adult patients, children are not going to give us their own history. So we need to be very patient, and if the injury is observed, get as much history as possible. Although it seems like a fracture can be diagnosed by an X-ray, and that should be enough, that should suffice. The history is very important because we need to know the mechanism of injury and the magnitude of the force, because like I've mentioned before, we need to know if they have any concomitant injuries as well. It alerts us to dig deeper to know the mechanism. So we need to ask a very thorough history. Children are not going to tell us if they have pain, but we need to ask when it was, what the circumstances was, if it was observed. All these things are very important. So after taking a thorough history, we do a physical examination. And in orthopedics, we follow the look, feel, move principle. In any kind of trauma, any orthopedic case, we look, we feel, and then we try to move. So we look for any swelling, any bruising, any deformity. And deformity, by definition, it implies fracture. So we know if it's a fracture. The only thing we don't know is what kind of fracture. So we look for deformity. We examine whether or not the skin is intact. This is very important. I know you covered open fractures recently, so we need to know if the skin is intact or not. It completely changes our management protocol. So we will look for the color of the skin. We check if there's any other associated injury in the region, in the whole body. And then we feel for any tenderness. We check the distal neurovascular structures, which is of paramount importance. And we check before and after any kind of intervention that we do, whether it's splinting, any kind of thing. So moving is very controversial. Although it's part of our pillar in physical examination, it's no longer recommended to move the injured site, because it inflicts tremendous amount of pain, and we might actually worsen the soft tissue injury the patient has already sustained. So I wouldn't recommend moving unless it's a very like a borderline kind of thing, and we need it to ascertain our diagnosis. So we move to how we investigate the patient. So X-ray is pretty much standard. We X-ray most of our patients if we think a fracture is possible. So the peculiar part about children is not the whole bone is visible on X-ray, because they have cartilage. The growth base is cartilage, and the articular cartilage is thicker than it would be in an adult. So in younger children, that might cause a difficulty. So that's why we have the rule of 2. 2 views we do for both adults and children. But specifically in children, we might need to take images of both limbs to compare, to see if there's any deviation, if there's any difference between the 2 limbs. And there are certain injuries that are associated with each other. Like if we have a calcaneal fracture, we need to do a spine X-ray and a pelvic X-ray, because these 2 injuries are associated. They're a result of fall. And then also in some difficult cases, when we're not sure that there's a fracture or not, we splint the patient, send them home, and then take an X-ray after 10 days, after 14 days. So 2 occasions. So I want you to concentrate on the last 3 in this list of rule of 2. 2 limbs, 2 occasions, and 2 physicians. This is important for pediatrics, because diagnosing, not missing a fracture is very important. So we need to be thorough. Like a single examination, even by an expert, might not suffice. So on our X-ray, we try to see if there is any displacements. And displacement could be because of force of the injury, because of gravity, and because of the pull of the muscles. So primarily, there are 3 components to displacement. There might be translation, angulation, or rotation. Out of these 3, in pediatrics, we are most worried about rotation, because it does not remodel. We need to correct. If there's any rotational component to the displacement, we need to intervene. There's no remodeling for rotation. But translation and angulation, unlike the adult population, we're far more tolerant, because they have a higher remodeling potential. So here you can see, this is what I mean by angulation. It can be forwards or backwards in layman terms, but I'm describing it as backwards and forwards because we're not specifically talking about a specific bone, but if we were, we would describe it using the plane the limb is found in. And then translation. This is what I mean by translation. It can be either an overlap or a sliding away from each other kind of thing with no component of angulation. So X-ray is our mainstay of investigation, but we might need a CT scan or an MRI. We don't use them commonly, but if we suspect there's soft tissue injury or a spinal injury, we might need an MRI. And in very rare cases, if there's a complex joints fracture, if there's a spine injury, if it's the fracture is at a site where it's not, if there's a lot of overlap and a 2D image is not going to suffice, we do take CT scans. And specifically, something I haven't included in my slides is in the pediatrics population, we also use ultrasounds. We didn't have high resolution ultrasounds and also MSK radiologists in the past, but we do now, and they're incredibly helpful. They do give us what would be called an MRI equivalent kind of reading, and they help us diagnose a lot of pediatric fractures, because as I've told you, they have a lot of cartilage, they have a thick periosteum. And in those cases, it's really hard to use an X-ray to make a diagnosis. So an ultrasound is also used in the pediatrics population. So what's different about a pediatric MSK or a pediatric bone? So there are multiple things that are unique about their skeletal system. One is they have a very thick joint cartilage, as I've told you. So the epiphysium is really small, which makes it hard to see on an X-ray. And in addition to that, and also because of the thick joint cartilage, we might not easily diagnose like dislocations and joint effusion, things like that. It makes it harder, but it gives them tremendous healing potential. In addition to that, which is very important in trauma, is they have really thick periosteum, which contributes to, one, keeping the fracture not displaced that much. So it kind of hinges it. It holds it contained because it's very thick. And in addition to that, it gives it tremendous healing potential. They have more collagen and more cancellous bone, more metabolically active bone, which heals faster. But they do have a growth plate, which is a liability. The most common site of injuries at the growth plates and the interface between the metaphysis and the growth plate, because it's a weak link. It's a kind of a site of change in density. So it's a common site of injury. In addition to that, they have really strong ligaments. So they fracture before they dislocate. This is important to note. That's why dislocations are not common in really young children. They fracture before they dislocate because their ligaments are stronger than their bone. Okay, so moving on. So which injury types are unique to the pediatrics population? Top of the list is physial injuries or growth plate injuries. These injuries account for 15 to 30% of all bone injuries in children. So a growth plate, like I've showed you before, it's that translucent cartilaginous disc separating the epiphysis and the metaphysis, and it's responsible for longitudinal growth of long bone. So in addition to that, so like all traumas, boys are affected more than girls, and upper limb injuries are more common than lower limb injuries. And the devastating thing about physical injuries is it affects the growth of that limb. So if we miss a diagnosis, if it's misdiagnosed, mistreated, or missed in general, it might have catastrophic consequences, including either growth arrest, resulting in limb length discrepancy, or they might end up in an angular deformity because half of the growth plate is damaged due to trauma and the other side keeps growing. So you can imagine it results in an angular deformity. So why I mentioned Volkmann's principle is, Volkmann's principle essentially says bone thrives or grows in compression, but the growth plate does not respond well to compression. So just a fun fact, this is why early age athletes, they never achieve their intended height. So they end up shorter than they would have genetically been because of this continuous loading on their growth plates. So why this is important is crush injury is possible for the physis or the growth plate, which is completely going to be missed on an X-ray. So a child comes to you, he's complaining of a fall, or he's a football player and now he has some kind of pain around the knee and maybe some swelling, and you just tell him to ice it and go home, but he might have had a crush injury to his growth plate and that limb is not going to grow as much as the other one now. So that's the catastrophic. So we should be like extensive in our investigation to find out, to rule out a growth plate injury. So in case they do have it, we need to de-stress it, or there are things we would do, but you need to refer that patient to an orthopedic surgeon. So talking about physical injuries is important, and the most common classification we use, and this should be on top of everyone's tongue, is the Salter-Harris classification. So a lot of people are familiar with it. It's important to understand it, what the implications are, and why it's important to classify physical injuries. So type 2 is the most common, let's note that, and type 5 is the worst, and it's really difficult to diagnose. So in type 1, it's kind of a slipping. It's through the hypertrophic zone, so the proliferative zone is spared, so they might not have any growth impediment in the future because their proliferative zone is protected. And also in type 2, the fracture extends into the metaphysis, so the proliferative zone, which is on the side of the epiphysis, is still protected. However, in 3 and 4, the fracture passes through the proliferative zone, which means there is a risk of growth arrest or angular deformity in these patients. So they cannot be treated like type 1 and type 2 patients, and they need surgical intervention. So for you, it's important to know what type 2 looks like, because it's the most common one, but it has a good prognosis, unlike 3 and 4. 5 has the worst. It's a crush injury. The whole plate is crushed, and restoring growth in that growth plate again is going to be near impossible. So it's really difficult to, even for a trained eye, to find these fractures in an X-ray is very difficult. So it's important to keep an eye out at all times. So here it is. There are other classification systems for pediatric physical injury, but they're not as commonly used, and they're really not important. They are more important for researchers, because the Peterson one, for example, it's the newest and it's the most thorough, but it's more complicated, and it doesn't have any, at least not yet. It's not clinically used. We don't use it to communicate yet. So the other peculiar fracture type for the pediatrics is the green stick fractures. Here's a very good example. Here you can see what a green stick means and why a green stick fracture happens. So a green stick, a wet green stick, is it's not brittle, right? It's weak, but it's not brittle, it's flexible. So the same applies for a young bone. Because of the high collagen level, it's not, the pediatric bones are not as brittle, but they are weak. So owing to large part to the thick fibrous periosteum of the immature bone, one side will break and the other side hinges. So it's a kind of incomplete kind of partial fracture. This is very common, but it has really good prognosis. So the other common type is a torus or a buccal fracture. This happens because of impaction. It happens between the metaphysis and diaphysis junction, and it's kind of an impaction kind of fracture. It's a very benign fracture, usually heals in a week or so time. So torus, the word means protuberance or swelling. And here you can see the red pointer shows a kind of swelling. So it's a compression kind of fracture. Another common fracture type or deformity type we see is the plastic deformation or plastic bowing or the bow fracture, where the bow is curved because it's irreversibly elongates on one side and the compressive side is still intact. Both sides are intact, but the convex side actually has gone through a irreversible deformation or increase in length. So these fractures can have a permanent deformity. They're not benign. These ones are not actually benign. They might result in a permanent deformity. So what we do is we complete the fracture we fracture this bone and then like try to put it back and then hope it heals as fast as possible, especially in sites like the forearm, because any kind of deformity there will result in impingement of one bone on the other. There are two bones there. So now we come to injuries that are indicating child abuse. This is important because child abuse is the second most common cause of death in children following accidental injury. And 90% of fractures due to abuse occur in children less than 5 years. And 50% of fractures in children less than 1 year are attributable to abuse. These are, of course, Western stats, but I don't have the stats for our country, but of course, abuse is ubiquitous, and musculoskeletal injuries are an early telltale sign of child abuse. And the most common cause of femur fracture in non-ambulatory infants is non-accidental trauma. So types of child abuse can be neglect, physical abuse, sexual, or psychological abuse. We're talking about physical abuse, of course. So the thing is, we have to have a keen eye for picking children who have been abused, because it's reported that 30–50% chance of repeat abuse is there, and 5 to 10% chance of death because of abuse. So it's not a one-time event. Usually children are abused multiple times, and if they ever come to us, we should not miss it. We should know what to look for and then protect them. So how do we approach it? In our history, we need to look for any inconsistencies. If we have any suspicion, if the history doesn't line up with the kind of fracture the patient presented with, if the fractures are old, if there's any delay in seeking care, and if there's any other injuries like to the skin, if there are any bruisings, old signs of injury, and if the X-ray survey shows multiple fractures in different stages of healing, those are telltale signs for child abuse. So although I'm not sure about our country's protocol, but I'm sure you can talk to the social worker wherever you work at, and there's something to be done about it. It's not a hopeless cause. We have had child abuse patients, and we have had to keep. I remember we kept one of our patients who had a very trivial fracture, who could have been sent home. We admitted him and kept him for 3 weeks with us until we could process, make sure he's safe. Like his stepfather was abusing him, so we kept him in the hospital as long as was needed to make sure that it doesn't happen to him again. So there are steps you can take to protect children. So these are risk factors from a study I found. It's not a study done in our country, but you can go through it. So what do we look for in children when we suspect child abuse? We should look at the whole body, see for any skin burns, bruises, any lacerations, hematomas, and skeletal trauma is the most common. Like 80% of them will have some kind of fracture. So we need to do a skeletal survey. So which ones are common and which ones do we usually find? So it's like location specific. If we find a long bone fracture, like lower limb fracture in a child that's not ambulating yet, that's a good sign that there's child abuse. What we collectively call like metaphyseal lesions, like a corner fracture or a bucket handle fracture. I'll show you images of what those might look like. And if we find multiple fractures, different stages of healing, if any kind of like skin bruises, and if they tell you, we don't know what happened, that's one of the common things. Like the child will have like a hand fracture or a rib fracture or a spine fracture, and they'll tell you nothing, we don't know, nothing happened to him. You should add up the history and everything else and then act upon that. So this is what I mean by a corner fracture. It's a product of traction and rotation. So it's a kind of a metaphyseal lesion. And here you can see the pointer pointing at it. This is what it will look like. It seems like a very small like nick, right? It seems like a very trivial small nick, but for this fracture to occur, there must have been like tremendous amount of like twisting with traction. It's a rotation injury. It's not something you'd find in a healthy bone. So this is almost pathognomic for child abuse. And also another metaphyseal lesion is the bucket handle lesion. The same mechanism, like a traction and rotation kind of injury. Here, healing posterior rib fracture. All these are indicative of child abuse. So when we come to generally managing pediatric trauma, we need to set out treatment goals. So our goals will be to restore length and alignments, especially rotation, and keep any residual angulation as small as possible, close to, especially because although they have tremendous remodeling potential, we shouldn't abuse that, and we should try to restore any kind of length issues, any translation, any angulation, and try to do a closed reduction. So the principles of fracture management are generally the same for adults and children. We need to stabilize the patient. We need to give proper analgesics, and then follow these 3 rules, which are fundamental fracture management rules: reduction, maintaining the reduction, and then rehabilitation. So what reduction would look like, what maintaining reduction would look like, depends on the fracture type, and also depends on the age of the patient. So so we do reduction, closed reduction for the most part in pediatric age groups, but we might sometimes need to do an open reduction and internal fixation for. So for reduction, we might use manipulation and also methods like traction. In children, we use skin traction. So to maintain our reduction, we immobilize. And to immobilize, we might again use operative or non-operative techniques. Usually in pediatrics, we cast and also maybe apply traction. Rarely do we operate unless there is a clear indication. So although casting techniques require a practical session, I'll just tell you the indications. So we might splint temporarily. It might be a definitive treatment. We sometimes use it for deformity correction and also temporarily treating pathological fractures. So these are what it would look like. So I will not go through all of this, but it's important to note that we take into account the child's age when we decide what an acceptable reduction is, because remodeling potential varies with age. So the older the child is, the less remodeling potential they have. In addition to that, where the fracture is also matters. The closer it is to a joint or the growth plate, the higher the remodeling potential. If the fracture is in line of the joint motion, the adjacent joint motions, chances of remodeling are higher. So we take all of this into consideration. One thing you should notice, if there is any kind of rotation, that's not never tolerated. We almost never tolerate. We never tolerate rotation. That will not remodel. Please note that. Like if a patient ends up in your hands, either after treatment and their casts are loose, or they have never been treated and the fracture is somehow healing because they heal really fast, but they have a rotation deformity, that requires referral, even though if it's healed, because we need to correct it. Okay, so when do we operate? Like I've told you, the indication for operation increases with the patient's age. So here you can see in really young children and infants, we very rarely do surgery unless it involves like it's an intra-articular fracture. But the older they get, we often do. So the more closer they are to adult age, then we do surgery a lot more. So what are the indications for surgery? One is open fracture. Always open fractures are always operated on, always debrided, and always stabilized. Displaced intra-articular fracture, that means Salter-Harris type 3 and Salter-Harris type 4 fractures. Fractures with a vascular injury, compartment syndrome, fractures that are not reduced by closed reduction, that can be because of soft tissue imposition, buttonholing of periosteum, like periosteum might work against us and prevents closed reduction. And if the reduction cannot be maintained in a kind of functional positioning. So if we have to put the patient in a very abnormal position in order to maintain our reduction, then they're better off being operated on. So here are some of the ways we use. Like I'll just show you images of our tools, I guess. We often use K-wires in our patients. The most commonly used implant in children has to be K-wires. And then we also sometimes we use plates. And then specifically for pediatrics, we use a flexible intramedullary nail. So you might see this in your patients. Someone had this done for them. So yeah, it's nice. It's good to be familiar what it would look like and why it's done. So we're kind of, I guess I'm rushing, but like, okay. So we should go through complications of fractures. So generally, we look at fractures as complications to fractures. We classify them as early complications and late complications. So we need to have an eye out for these at all times. So early complications we expect is associated injuries like visceral injuries or neurovascular injuries, especially neurovascular injuries. They're very commonly associated with fractures, because some surgeons actually say fractures are soft tissue injuries with a broken bone. Like, there's no way there's no soft tissue injury. There's always extensive soft tissue injury, because if the impact is strong enough to break a bone, then it definitely went through some soft tissues, and there will be damage to associated to the surrounding soft tissues. So it's good to think of that. Hemarthrosis is an early complication. That's bleeding into the joint, and we may see infections, especially in open fractures, and maybe sometimes not even in open fractures, because there are studies showing that even in closed fractures, if there is a hematoma, that could be a focus for bacterial seeding, because at any given time we have bacteria circulating in our blood, and that might seed in the hematoma, and we might have infection. So because the symptoms of fracture are very similar to infection, we need to have a high index of suspicion. Another common complication is the compartment syndrome, which is one of the few orthopedic emergencies. If we ever operate after midnight, it's mostly because of compartment syndrome. We rarely do, but the most common cause is compartment syndrome. And another early complication is the cast syndrome, and I'll tell you what it is, and I'll show you some images. So this is just to almost a revision of anatomy, just to show you which nerves and which vessels would be affected, so you know what to think of. If a patient has a shoulder dislocation, think of the axillary nerve. You need to check for the axillary nerve when you check distal neurovascular structures. Femoral shaft is associated with radial nerve, and the like. Supracondylar fractures, which are common in children, usually injure the radial and medial nerve. Elbow medial condyles are associated with ulnar fracture, ulnar nerve injury, which is a very rare nerve injury, and the like. So it goes on. So out of the early complications, the one we need to thoroughly understand and keep an eye out for, and which is also the most limb-threatening one, and which has a sequelae of this disability later on if we don't treat it early, is compartment syndrome. So what is compartment syndrome? Compartment syndrome is essentially increase in pressure in a confined compartment. So if a fascia is bounding a bone and muscle, if a fascia is bounding a muscle within a compartment created by a bone and a fascia, then that muscle is going to be in a tight compartment. And any increase in the pressure after that threshold, it will result in ischemia of the structures of the compartment. So it will restrict the blood flow to the area, and it will result in damage to muscles and nerves. So the tolerance, the amount of time a muscle will tolerate ischemia is 6 to 8 hours, and much less for nerves. So once ischemia sets in, it's practically irreversible. And the compartment syndrome is usually common in areas where there's tight compartments, like the forearm and the leg. It's very rare in the thigh because the compartments are larger. So yeah, this is just to lay it out for you. So there is an injury or insult. There will be swelling, either increase in pressure an internal injury or are cast, anything that increases the pressure in that specific compartment, and there'll be venous congestion. So first, the veins are not draining. That's what happens. That will further increase the pressure in the compartment, and because of this, there'll be a backflow. So the capillaries will not provide blood to the tissues, and that will result in hypoxia and cell death, and also further edema. So it's a vicious cycle of further swelling and cell damage, resulting in complete necrosis. So yeah, this is compartment syndrome for you. So what's different about compartment syndrome when it comes to children? So adults will tell you what their symptoms are. When they have pain, they'll tell you, I'm in pain. And when they have paresthesia, they'll tell you they have paresthesia. Paralysis, they'll be more vocal about their symptoms. But in children, we need to look out for the 3 A's. We need to look out for increase in analgesic demand. That means pain out of proportion. So if the pain is increasing, they'll require more analgesics. So we need to keep that in mind. And if the patient is just generally anxious and agitated, we need to think of compartment syndrome. And it's always better to overdiagnose when it comes to these kinds of surgical emergencies than to underdiagnose. You don't want to miss compartment syndrome on your watch. You need to always keep an eye out for that. You need to prevent it, and then if it happens, it should be operated as soon as possible. So look for analgesic requirement increase, anxiety, and agitation in the patient. So I've told you about CAS syndrome before. So we use hip spicas, the one you see in the image, a lot, not just for fracture, usually for femur fracture, but we use it for a number of indications. So one of the most scary complications about this is it could lead to obstruction. It can lead to duodenal obstruction. So the superior mesenteric artery will impinge on the duodenum, and the patient will have like vomiting, abdominal distension, and this is an emergency. They need to be cut out of that cast as soon as possible. So look out for that. It might not be, and it might be the spica. It might not be a authentic, like genuine abdominal complaint. So if a patient in a spica starts vomiting, complaints of abdominal distension, think of CAS syndrome. So late complications. So after a cast is applied, we should look up for pressure sores like cast burns. If an area is not well padded, they might have that. Non-unions are rare, but malunions and delayed unions they might be there. Delayed union, non-union, not really a serious concern in children. We're more concerned about malunions than anything than non-union, of course. Non-union is very rare because they have high healing potential. Avascular necrosis, it's possible. Again, not as common as it is in adults, but it's still possible. Another late complication we're afraid of in children is growth disturbance. We see that a lot in fractures that are missed, and even in fractures that have been treated in hospitals. They're easy to miss unless you know what to look for. So it's good to keep an eye out for them. Another complication is myocytes ossificans or heterotrophic ossification. Again, because they are more prone to this than adults because they're bone formers. They are more metabolically active, so they will have this, especially around the hips. If any kind of fracture around the hip, around the elbow, they might have that. So if they're stiff, we would suspect atro. Ischemic contracture or Volkmann's ischemic contracture is a sequelae of missed compartment syndrome, and it's a devastating sight. Honestly, in our setups, you'll see it a lot. You shouldn't, but we see it a lot. Even for trivial fractures, they develop compartment syndrome because of external bandages applied by like traditional bone healers. They do that a lot. So tight splinting is a huge issue for us. We see a lot of that, and as a consequence, we have even had to amputate patients because they've gone gangrenous because of the splint. But we see Volkmann's ischemic contracture a lot more. And joint stiffness is very rare because children, the minute the pain goes away for them, they're going to move their bodies. They're not going to malinger. So they don't generally suffer from joint stiffness. And Sudeikis dystrophy also not very common in children, but so these are common in children. Supracondylar humeral fractures are very common in children, and you'll see a lot of compartment syndrome associated with that. So as a consequence, we see a lot of Volkmann's ischemic contracture. They might also have cubitus valgus, which is a result of usually malreduction, and they'll have like a varus deformity at the elbow, cubitus varus. And refractures common in the lower limb, we might see it. Long bone fractures might result in overgrowth. That's why we tolerate opposition or like bayonet opposition in pediatric fractures. And non-union, although very not common, but at specific sites where the blood flows slower or like precarious, we see non-union. And AVN or osteonecrosis, not that common, but we see it at the femur neck and the talus. Okay, so this is a complication we see after a physial injury. So this thing you see, the connection between the two bones, this is what we call a physial bar. This is the result of a physial injury where blood flow is introduced to a site where there should be precarious blood flow, and that results in new bone formation. So a physis that should have been in continuous growth now arrests, and then a bone forms. So a bone bridge will form. So what this does is either arrest growth or result in angular deformity. So how we manage it will depend on the size of the physial growth. But if you see this on an X-ray, it's not a healthy site, and it will progressively result in more deformities. So pressure sores or cast burns are a result of not properly applied casts. So here you can see like the skin is necrotic and it's sloughing, and it might get infected, and it can be devastating and extremely painful. So we need to apply our casts properly, even if it's for temporary splinting. Like if you want to refer a patient and you want to splint them, you want to pad them enough that this doesn't happen, but at the same time not over pad that the fracture will move. So it's a balancing act, it's a skill, but make sure that their skin is very sensitive. So if the cast, it burns. So if it touches their skin, this is what's going to happen. And if we don't pad them well, this is what follows. So this is what I was talking about. This is Volkmann's ischemic contracture. This is a result of the whole forearm muscles being replaced by a non-elastic fibrous tissue. So where there used to be muscle, now we have a scar or a fibrous tissue. So the hand is now out of use because the muscles of the forearm are what make our hands functional for the most part. So here you can see a supracondylar fracture, which probably resulted in compartment syndrome, and now the patient has a Volkmann's ischemic contracture as a result of that. Same thing with the toes because of a leg compartment syndrome. Although this is not common, we might see it sometimes. It's what we call the complex regional pain syndrome or Sudeikis dystrophy. The pathophysiology behind it is it's controversial, but it might be a sympathetic dysfunction, and it results in like regional osteoporosis. The leg might appear like it's acutely like injured, like it will be swollen, red, shiny, and they'll have like on X-ray they'll have regional osteoporosis. They have tremendous amount of pain. It's quite devastating, debilitating. The treatment it's wide ranging, and they don't really respond to common analgesics as much. So this is what an HO is. Here you can see why the elbow would be stiff. There's a bone formed right over the joint, right in the soft tissues. So this is also a result of some kind of trauma. In children, we might even see it following like soft tissue injury, just a trivial like soft tissue injury or any injury to the muscle will result in bone formation within the muscle. And this is what they end up with. So we're coming to the end. So the take-home message, or what I want you to keep in mind from this this seminar is, although non-union failure to unite is very rare in children, malunion is not, specifically rotational malunion, and it might have like lifelong consequence. It might be debilitating. So if a patient comes to you with a fracture that's a week old, 2 weeks old, healed, they might not even have as much pain. But if they have some kind of a rotational deformity, they will have a lifelong deformity. And the older they get, the harder it is to correct. So please keep an eye out for that and refer your patients when you have that kind of patient. And in children, usually we manage them non-operatively. Not every fracture will require a referral. So it's important to familiarize yourself with the common kinds of fractures and what you can manage in your setup. So things that, because in most cases, we don't operate on pediatric patients. So like if you have to refer them from a distance, don't do it. Some of them you need to know and just manage yourselves, but you need to be aware of which ones require specialist care. And also think about child abuse all the time. Like I've said, 50 to 80% of child abuse patients will have some kind of musculoskeletal manifest. So keep an eye out for that. And also carefully examine patients for pathological fractures, because they don't tell you the mechanism of injury, don't know the magnitude. You might miss pathological fractures. In adults, it's pretty obvious most of the time. They'll tell you they fell from their bed and now they have like a hip fracture, which cannot be a thing, which cannot be unless they have a pathological lesion. But in children, it's not that obvious. And also remember the rule of 2. So remember to take images of both limbs if you're in dilemma, if you don't know if there's a fracture or not. Image both limbs, image on 2 occasions, and then also get a second opinion. So 2 physicians, 2 limbs, 2 occasions, and 2 physicians. These are important for specifically the pediatrics. Of course, I'm sure you're familiar with the 2 views rule, which is for all kinds of fractures. And also think of compartment syndrome at all times and overdiagnose, and don't underdiagnose. It's better to overdiagnose than underdiagnose. It's better to do a fasciotomy for a healthy compartment than actually miss one, because it's a lifelong disability and it might even result in a patient requiring amputation. So if you have any questions, I'll be happy to take them. And that's all I have for you today.
Thank you so much, Doctor, for the amazing presentation. So participants, please write your questions only in the Q&A section only. So Dr. Alpha will address those.
So the first question is, my question is on how to approach children who are victims of abuse in our setup, like who to contact and how to deal with the parents. Yeah, so that's a really important question, and it's something we struggle with as well. So we do have, I think in a hospitalist that I have worked in Addis and also in other cities, they do have social work. So they do have social workers, actually. If you take the initiative and contact them, they do what they can for them. I've had one experience where we had a child who had like multiple bruises, multiple fractures, and the mother brought him and she didn't tell us. She couldn't tell us the history. She was hiding. It was obvious. So he had a trivial fracture. I forgot what the fracture was, but we admitted him anyways. We put him in a cast and we admitted him because that's our right. Like, of course, she can refuse, but we compelled her to stay. We told her he needs to be admitted because we wanted to protect him and then work it out. And then social workers in the hospital were contacted, and they did what they can. I think they investigated. It was the stepfather. He got arrested, I think, or they did something. So we found out that it was the stepfather abusing him, and so I think to some extent it brought light to the situation. So it's better than nothing. I mean, we shouldn't just give up on them. I know, like the legal system might be a struggle, and we might not think that we might be able to do much, but at least we can admit our patients. No one's gonna prevent us from doing that, right? And protect them in that way and do what we can. So That's my experience with that. I'm not, I know like guardians have a lot of power when it comes to children in our country. Like the mother could have refused, she could have taken them home. There isn't much we can do, but we can try. So yeah, that's it. So why is the reason for boys are more greater in bone fracture than girls? I would think it's because for the most part, boys are more physically active than girls would be. They play more, so they fracture more. What's the #1 fracture in our country for pediatrics? It depends on the patient's age, but the most common for most preteens and below that has to be supracondylar fractures, and close second is femur fracture. So we see a lot of supracondylar humeral fractures, and those are not easy fractures. They're very devastating, both in terms of deformity sequelae, and also they're commonly associated with neurovascular injuries, and they're associated with compartment syndrome. So I would say it's supracondylar humeral fracture, not just for us, but all over the world. What's the difference between malunion and failure of union? Okay, that's a great question. Malunion is, there is union, there is no, there's biological union, but it's united in the wrong position. Either it has a residual residual displacement that we cannot accept, either a pronounced angulation, translation, that means shortening, or rotation. And out of all this, rotation is the most devastating. Failure of union is there is no link, there is no callus formed, or the callus is not strong enough between those two bones. So it's usually we say delayed union if there's no callus formed in 6 months, and we say failure of union or non-union after 9 months. Again, this is very general, and this is for adults. In children, we don't face it as much, but we take half the time. So like we need to see callus in three months, and by 6 months we diagnose like non-union. However, the reasons can be either biological or mechanical. So if a fracture is not stabilized, it's not going to unite. So a well-stabilized fracture doesn't unite, then we think of biological reasons, which can be a number of reasons: local, systemic reasons, including nutrition, general health, other comorbidities, anemia, and local problems like infection, superimposition of soft tissue, things of the like. So the difference between these two is malunion. There is union, it's just at a position that we cannot accept for functional for functional use of the limbs. Failure of union is there's no union. Yeah, so both malunion and non-union, or failure of union or delayed union, they all have their own management management protocols. Yeah, if there is a malunion and it's unacceptable, we'll refracture and reposition the limbs in an acceptable position. If that's a generally what we would do. And for non-union, malunion, we'll try to find the reason. Is it mechanical reason or biological reason? If it's a biological reason, what is the reason? And we try to address that. And if it's a mechanical reason, we'll stabilize the fracture and then follow up with X-ray. Okay, so in our setup, we use POP traction for adults. Can we use for pediatrics too? Yeah, so we have used POP traction for the pediatric age groups, but not for the really young ones, for the children that are above 10. The problem is we can use more weights with a POP traction, and that can be that can slough their skin. So it's a balancing act, because you know POP traction is a local invention. It's not a standardized way of applying traction, right? You know that. So we use it as a replacement for skeletal traction, and in adults, that is. And in children, we've used it, I think, a couple of times, but in older children, like above 10 years old, and then maintain, of course, the weight limit. How do we manage femur fractures in infants? Okay, that's a great question. In infants, we immobilize it. It depends. Like we usually use, if they're less than 6 months, we put like on them on public harness. If they're older children, we use hip spica for femur shafts fractures. That's a whole actually its own seminar. But generally, yeah, for less than 6 months, we do public harness, and for older children up to like six years, we do hip spica. And for neonates, we splint it with a spatula. What's the most common cause of pathologic bone fracture? A great question. In children, the most common cause is benign bone lesions. So there are a number of benign bone lesions, simple bone cysts, and also fibrous dysplasia, things like that. So benign bone lesions are common in children, and that's common in the pediatric age groups. How to manage of malunion when occurring long period. 1 month. 1 month is not we don't consider that a long period of time. Depends on the site, the type of malunion. It might be managed non-surgically, like if it's a fresh callus, if it's in the early stages, fracture healing, we will refracture it under sedation and then reposition it. But if the child is older, the fracture is old, we need to do an osteotomy, will require surgery and also internal fixation. So it depends on the case. Gold standard diagnostic modality for pediatrics traumatic injury in Ethiopia. I would say it's still X-ray. We use X-ray a lot. It's our main diagnostic modality, but there are specific areas, specific types of fractures that will require more than just X-ray. You might have to get a CT scan or an MRI, or sometimes, like I've mentioned, we use ultrasound more and more now because we have high resolution ultrasound and we have the right trained personnel for operating the ultrasound. As you know, the downside of ultrasound is it's operator dependent. For how long do we use plate for children because of growing the bone? Great question. So plates can be left in situ in adults, but in children they have to be removed because children have both longitudinal and transverse growth. So the plate will be buried in, and it will affect the growth of the child if we leave it in place. So once we ascertain the fracture is healed, we usually remove it. So that can range depending on the patient's age and also what we find out on our X-ray. So once we ascertain healing, we remove it. Like for example, for femur fracture, we remove it at 1 year. How can we apply traction for children? Okay, so the most common traction we use for children is skin traction. It's really difficult to explain how to apply traction. One would have to demonstrate it to truly show it to you. But skin traction is the standard for children, and that's the common traction we use. Sometimes we use POP traction. It's not a standard practice. You're not going to find it in any book. How to manage clavicular fracture in neonates? We leave it alone. No matter how displaced it is, we usually leave it alone because it will heal in a week. Usually in a week, within 10 days, there will be some level of union. Improper casting in arm, does it lead bone growth defect? Okay, I'm not clear on the question, but improper casting in arm does lead bone growth defect. Improper casting has its own series of complications, from malunion to cast burns to compartment syndrome if it's really tight. The most devastating one of these is, of course, compartment syndrome. So bone growth defect, I mean, I would imagine if it's bad enough, like if there's a rotation component to the displacement and I immobilize it in that rotated position, of course, they would have some sequelae to it. And if we miss a growth plate injury and we cast that, and then the patient eventually will have some kind of angular deformity or growth arrest. Bone growth defect, though, it's difficult because we can't cast for that long, right? For it to last long enough to cause growth defect. Yeah. So what is hip spica? Hip spica is it's a cast. It's a kind of a non-operative kind of way of managing both fractures and an array of conditions in pediatrics. We use it for DDH commonly, and then for femur shaft fractures. It's the cast that I've shown you on the image. So it can be a half spica or a full spica, like one full leg is casted and then it goes all the way up to the abdomen. Yeah, so the amount of weight we use, it shouldn't it should be like 7% to 10% max of the patient's weight. So it depends on how much your patient weighs. Okay, great. So I think that's it.
Yeah, I think there's one last question. It's on the top. So, is the traditional way of treating fractures, Wagesha, is guaranteed?
Oh, we generally don't recommend that health conditions get treated in non-health in a setup where that's not well regulated, and the personnel are not liable for their actions, or they're not going to be held responsible. We see a lot of complications because of the Wagesha care in our setups, and we have done a lot of amputations. We've seen a lot of Volkmann's ischemic contracture because of tight splint application. We've seen a lot of malunions, growth arrests, angular deformities because of a misdiagnosed fracture that was treated by a Wagesha. So I strongly advocate against them for the mere fact that they are a product of not having enough affordable service. I acknowledge that. We don't have enough orthopedic surgeons. We don't even have enough physicians. And they're a product of that. But they should become obsolete in time, because the harm they do is much, much more than whatever pain relief they give by splinting a fracture. So I strongly recommend against them. Is that it? I think
that's yeah, all of the questions. Thank you
great.
so much, Doctor, for giving your time for this amazing presentation on behalf of the participants and also on behalf of Blue Health. I would like to thank you so much for.
Great. Thank you, guys. It was fun.
Yeah. So thank you. Okay. Have a good night.
Okay. Bye. Good night.
All right.